Welcome to PGOG, Pathways to Growth in Obstetrics and Gynecology for Postgraduates and Consultants. Today's topic is male infertility, causes and evaluation made easy. Now, specifically, I'm using this word as made easy because this is comparatively we as gynecologists usually consider this as a difficult topic, male infertility. And the reason might be the gynecologists are not completely aware of so many causes of male infertility. How to evaluate is also not very clear. And usually, whenever there is any problems, even a small possibility of a problem, then the male partner is usually referred to urologist or a person who is trained in male infertility, and that might be the reason whenever this situation arises even in practice, whenever a male partner has any factor of infertility, we are not able to give justice to our counseling of the couple also. And in that way, I think as gynecologists we should be more aware about the various aspects related to the causes as well as how the evaluation needs to be done in cases of male infertility. Similarly, in for postgraduates, whenever there is a usually it is asked as a theory question in the examination, and whenever the question is related to male infertility, so many times even students also find it difficult to approach the subject. That way I have tried to make the topic as easy as possible. Male infertility as a sole cause is found in around 20% of the cases of infertile couple, whereas it contributes as one of the multiple factors in 20 to 40%. Now, the revision, just a short revision about the reproductive system, male reproductive system, and especially related to the testis. Testis has two components: seminiferous tubules, which contain spermatogonia, and Sertoli cells. Sertoli cells are secreting inhibin B. Leydig cells are present in the connective tissue in between the seminiferous tubules. So around in the interstitial tissue, these Leydig cells are present, and Leydig cells are mainly secreting testosterone. These seminiferous tubules are avascular, and these Sertoli cells, they form a blood testis barrier, almost on the line of blood-brain barrier, so that any that way, because of the formation of this barrier by the Sertoli cells, there is a protection to the which is provided to the sperms from various antigens and antibodies or various toxins. Spermatogenesis, around 100 to 200 million sperms are produced per day in the testis. Spermatogonium is undergoes mitosis. There is a formation of primary spermatocyte which is diploid having 46 chromosomes. It further divides into secondary spermatocyte. Secondary spermatocyte is haploid having 23 chromosomes, and then there is a formation of spermatids, 4 spermatids which are haploid and having one chromatid, and then there is further differentiation and the development of the sperm. So this is how from one spermatogonium we get 4 sperms. The whole of this process takes around 70 days. For the development of sperms from spermatogonium, the process is taking place, and it is a long process and it requires long duration of around 70 days. The these form sperms, they are stored in epididymis, and they are also, there is a further maturation of the sperms is also taking place in epididymis, and then there is a transport of the sperms which takes around further 12 to 21 days. So that is why we say that whenever we do semen analysis, it is showing us the status of spermatogenesis around 90 days before the timing of whenever semen was collected. It is giving us the idea about the status of spermatogenesis 90 days back. And that is the reason Whenever we want to repeat semen analysis, we need to repeat it at least after 4 to 8 weeks, so that we get the idea with if we are treating a male infertility patient with any treatment, and we want to see whether there is improvement in sperm semen analysis or improvement in count. In that case also we need to repeat it after a gap of minimum gap of 4 weeks, because otherwise it will not be showing us the effect of the treatment, because the whole process is taking place around 90 days. This is the practical significance of this knowledge for us. This is testis where the sperm production takes place. Then we have epididymis where there is a sperm storage as well as maturation, and sperm transport starts from here. And then a third organ is the vas deferens, that is a muscular tubular structure which leads to sperm transport. Seminal vesicles are contributing in a major way for the semen volume, as well as it produces alkaline seminal fluid, and from seminal vesicles only we get fructose. So three ways seminal vesicles are contributing in a major way. That is why I have given this star here. It is providing the alkaline content of the semen. It is contributing, seminal vesicles are contributing as a major component contributor for the liquid part of the semen, and it also provides fructose which helps in nourishment of the sperms. Now this, from this seminal vesicles, a tube joins this vas deferens, and after that, once the seminal vesicle tube joins the vas deferens, the combination or joining of these two with each other leads to the formation of ejaculatory ducts. Ejaculatory duct then enters into the urethra, and that is how through the urethra the sperm deposition, through the urethra orifice sperm deposition takes place. Before that, the prostate is in vicinity of the urethra, and prostatic fluid also contributes to some extent to the formation of semen, and it is mainly prostatic fluid is acidic in content. So prostate provides acidic secretion into the semen, whereas seminal vesicle mainly alkaline component is present. This diagram, I think that it should be clear, and the students especially should be able to draw this diagram, and it gives us so much of idea about the clinical application of this knowledge. Once we are very thorough in this anatomy, it helps us a lot in understanding male infertility, and that is why my request for the postgraduate students is to try to draw this diagram at least 2-3 times. Now, how the hormonal regulation takes place in in males is from hypothalamus, GnRH is getting secreted, acts on anterior pituitary. Anterior pituitary is secreting FSH and LH. So here there is a complete differentiation or two cell theory, same as female. In females, that LH is acting on Leydig cells, FSH is acting on Sertoli cells. It is easier to remember LL. L of LH for Leydig cells. That is how I have remembered it. So LH is mainly acting on Leydig cells, which is secreting testosterone. FSH is mainly acting on Sertoli cells, which are secreting inhibin B. Testosterone has a negative feedback on hypothalamus as well as pituitary, and that is how there is a regulation of self-regulation of LH secretion by this testosterone. The level of testosterone increases, LH secretion will reduce. Level of testosterone falls, LH secretion will increase. Similarly, here it is inhibin B which is controlling the FSH secretion by the anterior pituitary by a negative feedback. So testosterone has no role in the regulation of the secretion of FSH by anterior pituitary is the important point. The hormone which controls the release of the FSH by anterior pituitary is inhibin B, which has a negative feedback on anterior pituitary for release of FSH. This anterior pituitary is secreting FSH. It has some indirect influence on Leydig cells also, that FSH in to some extent increases the number of LH receptors on Leydig cells, and that is how the Leydig cells are more responsive to the action of the LH. That is one action of FSH on Leydig cells, which is a minor action. Major action is of LH on Leydig cells for the secretion of testosterone by Leydig cells. Testosterone which is secreted is 5 to 10 milligram per day. Now this testosterone, as you can see, we can see here, it has three actions. One we have already seen is it has a negative feedback action on hypothalamus as well as anteropituitary. Second is it has action on the systemic action on the various tissues in the body, leading to the systemic action functions of the androgenic activity and function of testosterone. Third of action of testosterone is present in the or in the testis around the seminiferous tubules in a very high concentration. It is the level is 50 to 100 times greater than what is the level in the blood. And here what it leads to is it acts on Sertoli cells, and it helps in spermatogenesis. So testosterone is also required for spermatogenesis and sperm maturation. Sertoli cells, by FSH, Sertoli cells are secreting inhibin B is number one. Second, the substance which is secreted by Sertoli cells is androgen binding protein. And under the influence of this androgen binding protein, testosterone can act on the uh, Sertoli cells for the spermatogenesis as well as for sperm maturation also. Testosterone plays an important role. So we can see that there is a crossover, though we say these are the two separate. I have shown it with separate colors, as LH is mainly for Leydig cells and testosterone, FSH is mainly for Sertoli cells and inhibin B and spermatogenesis. Still there is a connection in between these two. As we can see here, FSH also stimulates LH receptors. Testosterone is necessary for spermatogenesis, and that is why what is most important concept is FSH and LH both are necessary for normal spermatogenesis. Now, whenever we start evaluating a male, then we have these 5 goals which are very important, and if we can answer these fulfill these 5 goals, then our evaluation is complete. First is to identify the males who are having treatable cause of infertility and then treat that cause. That is our first goal of evaluation. Second is in those who are where there is a non-treatable cause, identify a group where IUI or IVF will be of help. Third is to identify those male who have genetic abnormalities which can affect the offspring, so that even if we can do IUI, we can do IVF, we need to be cautious in this group because of the possibility of transfer of the genetic abnormality to the offspring. Fourth is identify those where IUI, IVF will not be of any help, and here the option will be either adoption or donor IUI. And last is whatever is the cause of infertility, if there is a possibility of having underlying medical condition which needs to be treated, we should treat that condition. So these are the 5 goals, and I think if we can answer the at the end of our evaluation and evaluation and for management, if we can identify for in a specific case whether the patient belongs to a case where the treatable cause is there, or we have whether we have option of IUI, IVF, or whether we have to go for adoption or donor IUI, whether there is any possibility of genetic abnormality which can be transmitted to the next generation, and whether the male partner is having any underlying medical condition associated with infertility which needs to be treated. Whenever the paternal age is greater than or equal to 40 years, it is considered as a risk factor for adverse health outcome for offspring, and this also needs to be included whenever we are doing counseling of a couple with infertility. There is increased risk of chromosomal abnormalities, point mutations, increased risk of congenital anomalies, schizophrenia, and autism. So that should also be included whenever we are counseling a couple. Coming to causes, unfortunately, around 40 to 50% it is idiopathic group where the exact cause of male infertility is not cannot be found by thorough evaluation also. Major chunk is 30 to 40% where there is a primary gonadal disorder, that is there is a testicular failure which can be either congenital or acquired. Third group is disorders of sperm transport contributing to 10 to 20%, and a very small group, only 1 to 2% is there where there is a hypothalamo pituitary disorder, such as there can be any cerebral tumor which can be affecting the fertility. It can be again this HP disorder can be congenital, acquired, or because of any systemic illness also, but it is contributing to a very small proportion of patients having male infertility. Whereas if we see the causes after idiopathic, main is testicular disorder, primary testicular disorder. It is the most common cause of male infertility. Now, causes of primary gonadal failure, where the problem is at the level of testis, that the spermatogenesis is getting affected. So, what are the causes? Various causes of primary gonadal failure are it can be because of genetic abnormalities such as Klinefelter syndrome or Y chromosome deletions. There can be cryptorchidism, that is undescended testis. Presence of varicocele can be there. Infections can lead to such as mumps, orchitis, chlamydia, gonococcal infection. These can affect the testis. Drugs can lead to the problem in spermatogenesis, such as alkylating agents, androgens such as spironolactone. Radiation can affect spermatogenesis, and chronic illnesses, liver or renal failure also can lead to problems in spermatogenesis. So this is a list of causes of primary gonadal failure in males or causes of testicular failure or problem is at the level of testis leading to the problem in spermatogenesis or formation of sperms. In short, we'll see some of these conditions. Filter syndrome is the most common cause of primary gonadal failure. It is also called as hypergonadotrophic hypogonadism because here testosterone is less and FSH is more. Klinefelter syndrome is 47XXY, one extra X chromosome is present. This is the most common type of genetic abnormality in Klinefelter syndrome, but other genetic abnormalities also can be leading to Klinefelter syndrome, such as 48XXXY, 46XY, 47XXY as a where there is a mosaicism. 46XX males. Here, what is happening is there is a translocation of SRY gene on X chromosome. Usually, with Klinefelter syndrome, the person is tall. There is a reduction in bone mineral density. There is associated gynecomastia, short penis, and cryptorchidism is also common. There is increased FSH-LH level, fall in testosterone, reduction in sperm count, oligozoospermia is severe, and associated psychosocial abnormalities are also found. Y chromosome microdeletions leads to either azoospermia or severe oligozoospermia. Its importance is genetic transmission to sons is a possibility if ICSI is intracytoplasmic sperm injection is used in these cases, and that is why it needs further counseling. Cryptorchidism is low, where the undescended testis where there is a low fetal androgen. In fetal life, androgen level for any reason is low. It will lead to either unilateral or bilateral undescended testis. With the undescended testis, it leads to impaired spermatogenesis. There is increased risk of testicular tumors also. So these are the two effects of this undescended testis, that the spermatogenesis is impaired and there is a increased risk of testicular tumors, especially malignancies. The risk is very high. Here there is a raised FSH but normal LH and low testosterone. As we have already seen that this uh, whenever there is a spermatogenesis is problematic, the what will happen is these Sertoli cells are at a are having problem, and these are secreting less number inhibin B, and that is why there is increase in FSH, whereas LH usually remains normal. There is low sperm count proportionate to the duration of cryptorchidism. So if it is surgically corrected earlier, then oligospermia is not very severe. Varicocele, there is dilation of pampiniform plexus of spermatic veins in scrotum. How it leads to infertility is still a question mark. Exact mechanism is not known. Possible mechanisms are because of this dilation of the pampiniform plexus, there is increased local scrotal temperature that might hamper the spermatogenesis, or delayed clearance of toxins, presence of stasis, or hypoxia. These are all the theories which have been proposed how varicocele leads to defective spermatogenesis. Now, the second group is disorders of sperm transport. For this, again, we have to revise that how the sperms are getting transported. They are produced in testis, stored in epididymis, then it is transported mainly by vas deferens. Seminal vesicles are the duct from seminal vesicle joins vas deferens. Then what is formed is called as ejaculatory duct. This ejaculatory duct joins urethra. Here the prostate is surrounding that part of urethra, and then through urethral meatus, sperms are getting deposited in vagina. So various levels at which the disorders of sperm transport can be there is, first is there can be epididymal obstruction or dysfunction. So epididymis itself there can be obstruction. Second is there can be congenital bilateral absence of vas deferens. This is CBAVD, is congenital bilateral absence of vas deferens. Then infections such as gonococcal infection, chlamydia, or tuberculosis can lead to the obstruction of vas deferens. Vasectomy will lead to disorder of sperm transport if patient now wants to again have a uh, conception. In Carter syndrome, abnormal ciliary function is there. Young syndrome, there is inspissated secretions and that hampers the sperm transport. Ejaculatory dysfunction can be there because of the spinal cord disease, and then the ejaculatory duct obstruction also can be there, that leads to the that hampers the sperm transport. Now we will start with the evaluation of male infertility. We have seen in short about various causes of male infertility, and now the next part of our today's this topic is evaluation of male infertility. Various ways of evaluating male is, first is detailed history, that is the part of initial evaluation. After history, so many now it comes naturally to us that history and examination, but this is a topic where there is somewhat the our usual way of dealing with any clinical situation differs. Here, after history, we have to go for semen analysis as a part of initial evaluation. And if semen analysis is showing abnormal parameters are present, and more than one parameter is abnormal, multiple abnormal parameters are greater significance as compared to a single parameter showing abnormality, that is there, then we go for examination by expert. So that means examination of the male partner is not a component of initial evaluation. Initial evaluation in male infertility includes history and semen analysis, and examination is by usually by expert, as I said at the start only, that usually we have to refer the male partner to urologist or reproductive medicine expert, and examination of the male partner is done by that expert. So examination is done in not in all cases, only done whenever it is indicated. After that, if indicated, endocrinal evaluation is to be done, urologic evaluation is to be done, and genetic evaluation should be done. So this is a part of how the uh, decision making about evaluation goes. What is not recommended is anti-sperm antibody testing as a routine is not recommended at present, as it has a doubtful role in the development of male infertility. Diagnostic routine testicular biopsy in cases of azoospermia is absolutely not indicated, because we have better ways of differentiating between the cause of azoospermia, as either whether it is an obstructive type of azoospermia or non-obstructive type of azoospermia. So routine testicular biopsy is to be avoided. Routine imaging has less role in evaluation of male infertility, such as ultrasonography, MRI. It is done only in few indicated scenarios. Vasography is also not indicated to see where the block is in patients with obstructive type of azoospermia. So all these techniques were used in past, but in modern gynecology, these are not recommended. In history of undescended testis and whether it was corrected and at what age it was corrected, especially to rule out testicular atrophy. Delayed correction of undescended testis will lead to testicular atrophy. Mumps orchitis also leads to testicular atrophy. We have to take history of timing of secondary sexual character development, mainly to see whether there is any associated endocrinopathy. History of sexually transmitted diseases, because it will point to a possibility of a ductal obstruction, that is the obstruction of vas deferens. History of diabetes mellitus, because in diabetes there is a weakening of urethrovesical uh, and this at the level of the urethrovesical junction there is a weakness, and there is a that leads to the greater possibility of having retrograde ejaculation. Then history of cystic fibrosis, as cystic fibrosis is associated with congenital bilateral absence of vas deferens. If there is a by coital, we have to take coital history most important, and if there is ejaculatory dysfunction, then the cause of ejaculatory dysfunction might lie in the history itself. If there is a history of retroperitoneal surgery affecting the nerve supply, that can lead to ejaculatory dysfunction. If patient is on medication such as reserpine, methyl dopa, beta blockers, phentolamine, guanethidine, all these drugs also lead to ejaculatory dysfunction. So drug intake, history of drug intake is important. In surgical history, especially with the possibility of injuring the vas deferens, whether there is a history of inguinal hernia repair, renal transplant, because transplanted kidney is usually placed in lower abdomen, and whether there is any history of scrotal surgery. So that is how thorough history part forms. It is a part of initial evaluation of male infertility. Semen analysis, as we have seen, it forms the initial part of initial assessment of male infertility. Normal parameters which were considered till 1999 are called as traditional parameters, whereas 2010 the WHO has given us new parameters. Now, mostly the parameters are similar except volume now considered as initially it was 1.5 to 5 ml. Now it is considered 1.5 as normal. Concentration is same 20 million per ml, and now it is 15 greater than 15 million is considered as uh, normal. So not a much difference. Total sperm number for greater than 40 million per ejaculate, greater than 39 million per ejaculate. Total motility greater than 50% or 40%. Progressive motility greater than 2 on a scale of 0 to 4, 4 or 32% showing progressive motility is considered normal. The major difference is here, normal morphology. Previously, it was considered as more than 50% should be normal in 1988 WHO recommendation. 87 it was brought down to 30, and in 99 it was brought down to if it is greater than 14% showing normal morphology as normal. Now 2010 it is greater than 4% are having normal morphology, that is also considered as normal, as more and more advances in the management in male infertility are taking place. With that, there is a reduction in the necessity to have a number of sperms with a normal morphology. Vitality should be more 58, greater than 58% should be showing vitality. Now, if it is semen analysis is abnormal, it should be repeated after at least 4 weeks. 2 to 3 days abstinence is advisable before doing semen analysis, and the semen should be assessed within 1 hour of collection. Now, semen is having nourishing fluid and sperms. Major component of volume nourishment, that is fructose and alkaline content, is provided by seminal vesicles. We have already seen in the slide on the where we have seen the anatomy of male reproductive system. Seminal vesicles and vas deferens, they share common embryology. So whenever there is an absence, congenital absence of vas deferens, seminal vesicles are either absent or hypoplastic. Prostatic acidic fluid also contributes to semen formation to a lesser extent. Ejaculatory duct is joining of vas deferens with seminal vesicle ducts, which is proximal to the prostate. We have already seen diagrammatically in the previous slide. Now, if there is a low volume ejaculate by 2010, it is less than 1.5 ml. What can be the possibilities? What are the causes? Either it can be a failed emission, incomplete collection, or short abstinence interval, any of these. So we need to repeat the semen analysis and see whether it is repeatedly coming as low volume ejaculate. Then pathological causes can be hypogonadism, where because androgens are needed for seminal vesicles as well as prostate secretion. So anytime testosterone is low will lead to low volume ejaculate. In retrograde ejaculation also there will be low volume ejaculate, as main component of the semen will be entering the bladder. Congenital bilateral absence of vas deferens, if it is present, and if there are absence of or hypoplastic seminal vesicles, then also there will be low volume ejaculate. Ejaculatory duct obstruction will also lead to the low volume ejaculate, because in both of these situations, this is where congenital absence of vas deferens, and this is where there is a ejaculatory duct obstruction. In both of these situations, the semen will be having only prostatic component, and prostate is having a contributing to a small amount of semen, and it is mainly the acidic component, so that there will be low volume acidic pH of the semen less than 7.2, and absence of fructose, absence of sperms. This is strongly suggestive of a presence of any of one of these two possibilities. Now, if palpable vas deferens is there, then it is almost conclusive that there is a ejaculatory duct obstruction. I hope you remember that what is taking place. Again, I will try to draw the diagram here. This is the, say, testis, and this is the epididymis, and then there is a vas deferens which is going here, and here is the seminal vesicle duct. These are joining, so this is ejaculatory duct. This is the ejaculatory duct. So if bilateral absence of vas deferens, then also the main after ejaculatory duct will be joining the urethra, and here is the prostate. So prostatic component will only be present if either there is a absence of vas deferens completely, or this ejaculatory duct is having any uh, obstruction. Then also it will lead to, so either here there is obstruction, or here bilateral absence of vas deferens. In both of these situations, the main component, whatever is getting here in the semen, it is only the prostatic component. So prostate is mainly contributing to the semen here, and it will have a low volume. So it will be low volume ejaculate, mainly acidic, and no fructose and no sperms. That is how we know that our, and if there is a palpable vas deferens, then it tells us indirectly that our diagnosis should be ejaculatory duct obstruction. I hope the for this point is clear, because it is very important clinically how we diagnose ejaculatory duct obstruction. Now coming to azoospermia, no sperms after testing twice after high speed centrifugation of the semen, and looking for it under high magnification, 400 times magnification, and still absence of sperms, then we label it as a case of azoospermia. At least twice testing should be done twice. Classification of azoospermia as obstructive, non-obstructive. Obstructive is seen 40% of the cases it is obstructive, whereas 60% it is non-obstructive, where there is a impaired sperm production. Obstructive can be because of infection, trauma, inguinal surgery, or congenital. That is congenital bilateral absence of vas deferens. Non-obstructive can be because of primary testicular failure or secondary testicular failure because of the underlying other endocrinopathies. Oligozoospermia, whenever the sperm concentration is less than 15 million per ml, and severe whenever it is less than 5 million per ml. Causes of oligozoospermia are varicocele, hypogonadism. Hypogonadism is where the testosterone production is less, and that leads to the low sperm count. Microdeletions in Y chromosome is also a cause of this oligozoospermia. Hypogonadism can be because of anything which affects the spermatogenesis and testosterone production, such as even Klinefelter syndrome also. Endocrine and genetic evaluation is a must whenever there is a severe oligospermia. Complete endocrine evaluation as well as genetic evaluation is mandatory. Now there are two things how we calculate C for the sperm count. One is a sperm concentration, other is total sperm count, where semen volume is multiplied by sperm concentration per ml. Now both of these, sperm concentration and total sperm count, should be interpreted together. Asthenospermia, poor sperm motility, can be because of sperm autoantibodies is questionable. We have already seen anti-sperm antibodies. Usually it is nowadays not recommended as a initial part of evaluation. Genital tract infections can lead to reduction in motile sperms. Partial obstruction of ejaculatory duct, partial obstruction at vasectomy reversal site also can affect the motility. Presence of varicocele, prolonged abstinence, and Cartagena syndrome is a rare cause of asthenozoospermia. Teratozoospermia is abnormal morphology of the sperms, and causes are varicocele, primary testicular failure, secondary testicular failure. Now, here, the terminology which is now used is strict sperm morphology, where you need a trained person who will look at the sperms and strictly see whether all the parts of the sperm are normal or not. Any part is not showing, fulfilling the criteria, is considered as abnormal. By this strict sperm morphology guideline, if the normal is, if the number is greater than 4% are showing normal by strict, but it needs a trained person for remote reporting. So if that person is not there, then older values are used, where the normal is considered as number of sperms with greater than 14% of the sperm showing normal morphology is considered normal. But if we use the strict criteria, and if it is seen where it is needed to be examined by a trained person, greater than 4% is also adequate to call it as a normal semen analysis. Normal morphology is the best predictor of sperm function. Rather, when we compare the sperm motility, sperm count, and sperm morphology. Out of these three, sperm morphology is the best predictor of sperm function. Function is ability of the sperm to go for fertilization. Now, if there are presence of round cells in the semen, there are these four possibilities are there. Whenever the round cells are greater than 5 million per ml, then we have to consider these possibilities that round cells can be because of epithelial cells, presence of epithelial cells in semen, immature sperms. Prostate cells also look as round cells and leukocytes. Now, what we are mainly concerned about whenever we see round cells is whether there is any infection or whether leukocytes are present. But by routine semen analysis, we cannot differentiate between these various types of cells. For that, we need to do further testing by special stains, or we have to do the spatial staining or biochemistry or immunohistochemical testing. True leukocytospermia or pyospermia is whenever there is presence of greater than 1 million leukocytes per ml. By doing this further testing on the semen analysis, we can differentiate between leukocytes and these other cells, especially the immature sperms, prostate cells, and epithelial cells. And if there is a presence of this pyospermia, it is an indication to proceed with semen culture. But association of pyospermia and infertility is not proven beyond doubt is important concept. That whether pyospermia truly contributes to infertility is doubtful. Once we do the take history and do semen analysis, and then we decide whether to go ahead with male, examination of the male partner. And examination indications to examine to evaluate male infertility are specific indications are there. If there is abnormal semen analysis, especially with multiple abnormalities, it is an indication for a thorough examination of the male partner. If there is a history of trauma or surgery in the lower abdomen or groin area, then it is an indication to evaluate and examine the male by to know the cause of infertility. History of sexual dysfunction, history of failure of ART, or history of recurrent pregnancy loss that is greater than two losses is an indication to evaluate the male partner by examining the male partner. Examination includes whether there is gynecomastia, how is the stature, whether there are any features of endocrinopathy. Palpation of testis epididymis should be done. Palpation of vas difference, because absence of vas difference is a clinical diagnosis. Palpation for varicocele also should be done. PR examination to see whether the prostate size is normal, whether there is any presence of midline cyst, or whether there is a seminal vesicle swelling can be detected by digital per rectal examination. Now, this examination is done by urologist or reproductive medicine expert. It is This examination is not indicated as a routine. It is indicated with specially with these indications only. Coming to endocrine evaluation, indications to do endocrine evaluation of the male partner are if abnormal semen analysis, especially oligozoospermia with less than 10 million per ml count, sexual dysfunction is there, then it is, or decreased libido or impotence is an indication to do endocrine evaluation. Findings, if there are any findings suggestive of specific endocrinopathy, then it is an indication. So these are the three indications to proceed with endocrine evaluation in the male partner. Basic evaluation is by doing serum FSH and total testosterone. Low total testosterone less than 300 nanogram per dl, then we have to repeat it once again. If it again comes low, then the further evaluation is done by doing free testosterone, LH, and prolactin. Now here, hypothalamus is secreting GnRH. Again, this is a revision on anterior pituitary tax, and then under the influence of LH, testosterone is secreted by Leydig cells. Under the influence of FSH, inhibin B and this ABP is secreted by Sertoli cells. This is androgen. Uh, I'm sorry, this inhibin B and ABP. This is androgen binding protein and this inhibin B. And with that, there is a spermatogenesis which is taking place. Testosterone will be negatively reducing the amount of LH to be secreted. Inhibin B will be negatively reducing the amount of FSH which is being secreted. And testosterone is also having the peripheral action, also acting for the contributing or necessary for spermatogenesis bias in the seminiferous tubules. If there is an endocrinopathy, then what we have to focus is on FSH. High FSH, then we have to go for LH. In that case, if reduced or normal testosterone is present and raised FSH and LH is present, that indicates testicular failure. If there is a normal or raised FSH and normal LH and normal testosterone, then there is a possibility of having abnormal spermatogenesis. But if high FSH LH and there is a low testosterone, testicular failure is a possibility. All three are low, FSH, LH, and testosterone, and prolactin is normal, then it is hypogonadotrophic hypogonadism, where rare hypothalamo-pituitary abnormality can be the cause, where we have to proceed with MRI and CT brain. Fourth possibility is if raised prolactin is there, it is associated with fall in FSH and LH and normal or reduced testosterone, then there is a possibility of prolactin secreting pituitary tumor. Hyperprolactinemia can lead to this fall in FSH, fall in LH, and fall even can lead to normal or reduction in testosterone, and it can affect the spermatogenesis. So endocrinopathy, if we see there, these are the four main conditions where there can be a endocrinopathy leading to male infertility. Problem in testis, problem in spermatogenesis, hypothalamo-pituitary problem, which is seen in only 1 to 2%, and hyperprolactinemia can also lead to infertility. Now, urologic evaluation is done by urologist. It is indicated whenever there is a grossly abnormal semen analysis is present. If soft, small testes are present, it is suggestive of testicular failure. Epididymal fullness is suggestive of epididymal obstruction. Congenital bilateral absence of vas deferens is diagnosed clinically by palpating vas deferens. Varicocele is also diagnosed clinically by palpation of spermatic cord. Per rectal examination is done to see for prostate midline, presence of midline cyst, prostate with normal prostate or not, and whether there is presence of dilated seminal vesicles. First is transrectal ultrasonography is done only for suspected ejaculatory duct obstruction, where there is acidic low volume semen, no fructose, no sperms, and palpable vas. So this is the only indication to do transrectal ultra. If you are asked what is the indication to do transrectal ultrasonography in a case of male infertility, your answer should be suspected ejaculatory duct obstruction. Transscrotal ultrasonography is also done in with specific indications only when there is a obesity or there is a past scrotal surgery has been done or the small presence of on examination there is a small tight scrotum, then only we have to proceed with transscrotal ultrasonography. Renal ultrasonography is indicated whenever there is a congenital absence of vas deferens. Such vas anomalies are there, then to rule out congenital renal agenesis, especially unilateral congenital renal agenesis. For that, renal ultrasonography is indicated. Now, place of testicular biopsy, it is rarely indicated, not indicated whenever there is a azoospermia with raised FSH. Indicated whenever there is a azoospermia and normal FSH, normal testis volume, and when there are no features of obstruction, then only these are the rare situations. This is a rare situation where testicular biopsy will be of help. Otherwise, there is no need to see whether it is obstructive or non-obstructive cause of azoospermia. by doing a testicular biopsy. Tissue preservation for future IVF or ICSI should be done whenever testicular biopsy is being done. So it is diagnostic as well as therapeutic intervention. So that is the reason biopsy should be done at places having the facility for sperm retrieval and cryopreservation. This is most important. The testicular biopsy is to be done at advanced centers where facilities for sperm retrieval and cryopreservation are present. Genetic evaluation is done conditions likely, especially conditions likely to be transmitted to the offspring in presence of azoospermia or severe oligospermia. For these identification of these conditions, we do genetic evaluation. If there is congenital bilateral absence of vas deferens, mutations within cystic fibrosis transmembrane conductance inhibitor. It is called as CFTR, cystic fibrosis transmembrane conductance inhibitor. This for this gene, the mutations in this gene are seen in 75% of the cases of CBAVD, and that is why this testing to be done whenever there is a congenital bilateral absence of vas deferens. Chromosomal anomalies leading to testicular dysfunction are to be diagnosed by genetic evaluation such as Klinefelter syndrome 47XSY. Y chromosome microdeletions with abnormal spermatogenesis also need to be diagnosed by doing genetic evaluation. So what is done is whenever there is a CBAVD, screening for this cystic fibrosis TR mutation is to be done whenever there is either a congenital absence or there are even mild vas anomalies are there, unilateral absence of vas deferens, partial congenital block of the vas deferens, then also this genetic testing should be done. And in that case, female partner screening is also to be done if there is a positive result in male partner, because both can be heterozygous and offspring can have cystic fibrosis, and that is the reason this screening is mandatory. Karyotyping and screening for Y chromosome microdeletions is indicated. Karyotyping is mainly for Klinefelter syndrome, and screening for Y chromosome microdeletions is done by various other genetic testing. Karyotyping doesn't detect this Y chromosome microdeletions, but the testing for these is indicated whenever there is a non-obstructive azoospermia or severe oligospermia with sperm count less than 5 million per ml, whenever it is associated with elevated FSH with testicular atrophy, and whenever we want to use the sperms for IVF ICSI, then we need to rule out the presence of Klinefelter syndrome or presence of this Y chromosome microdeletions. Now, Y chromosome microdeletions are present on long arm of Y chromosome. This is the Y chromosome, this is short arm, this is long arm, and here there is a centromere connecting the short arm and long arm with each other. Now, azoospermic factor A, B, and C are present on this long arm. A is proximal, B is central, and this azoospermic factor C is at the distal end of the long arm of the Y chromosome. Now, with A, Z, F, A, and B, it is associated with poor prognosis. Some sperm retrieval is not possible. That is why we need to differentiate what is the type of microdeletion. If it is AZF, that is azoospermic factor C microdeletion, it is associated with either severe oligospermia or azoospermia. In these cases, sperm retrieval is possible, but one has to be cautious because it can be transmitted to sons, and accordingly we have to do the counseling of the couple. Now, coming to the summary, I think it is not the students especially might find it very difficult to reproduce this topic, and that is why I have summarized it once again. If there is a 1 year of infertility and age of the female is less than 35 years, then we should proceed with the assessment for infertility. But if age is greater than or equal to 35 years, then we have to start evaluation of infertility after 6 months. We can start evaluation. Simultaneous assessment of male and female should be done with detailed history whenever there is a couple approaches for with a history of infertility. Next step should always be semen analysis. If it is normal and normal coital history is there, then we can focus only on female evaluation. Semen analysis is abnormal, or there is any coital difficulty, or failed ART, or there is a history of recurrent pregnancy loss, these will be the indications to proceed with male partner evaluation. Now, in male evaluation, again, complete history and examination by expert is indicated. Depending on semen analysis, we can divide these male partners in three groups: oligozoospermia, normozoospermia, and azoospermia. Whenever there is a normozoospermia, we have to see whether there is any treatable cause for any abnormality contributing to the infertility and treat it, or we can proceed with ART. Oligozoospermia will be an indication to proceed for endocrinological evaluation by FSH and testosterone, and especially raise FSH, then we have to go for LH. For less FSH, we have to rule out prolactin secreting tumor, and for that we have to do further evaluation accordingly. If it is azoospermia, depending on the examination of the male and FSH, we can divide the causes patients with azoospermia in obstructive and non-obstructive. In obstructive, FSH will be normal, whereas in non-obstructive, FSH will be raised. Whenever it is a obstructive, if it is congenital absence of bilateral absence of vas difference, then cystic fibrosis genetic testing is mandatory. In non-obstructive, karyotyping is to be done for to rule out Klinefelter syndrome. Advanced genetic testing should be done for to rule out Y chromosome micro deletions. Now there is a rarely we have to proceed with the testicular biopsy. It should be considered as diagnostic as well as therapeutic option whenever FSH is normal. In spite of having normal FSH, normal testis, there is no evidence of obstruction. Then that means it is neither coming to this part or that part. This is a rare situation where we can proceed with testicular biopsy at a facility where the possibility of facilities for the sperm retrieval and cryopreservation is available. Thank you so much. I hope that at the end you find this topic a little bit easier than what you feel when you start reading this topic from the textbooks. I hope that now the video is not a replacement for your textbook reading. That is one advice I want to give to clinicians as well as postgraduate students. It is a supplement for your own understanding of the topic. And the main aim of preparing these videos is to facilitate you or introduce you to the various terminologies so that you find understanding the topic easier when you read it from the various textbooks of your choice. To prepare this topic, I have taken help from Spirops and Novak's gynecology. Along with that, I have gone through the American guidelines, this Urological Association Guideline 2020, Reproductive Medicine Society Guideline 2021, and this guideline is also very good. Urological Society of India Guideline 2022 helped me a lot while understanding and preparing this presentation. Thank you once again.